Bismillah ar-Rahman ar-Rahim. I'm Dr. Ashraf Amir. I'm a consultant in family medicine, International Medical Center, Jeddah, Saudi Arabia. I would like to welcome you for this session. And all of us as a practicing physicians, we encounter a real challenge in managing and handling our patients with bronchial asthma. And as you know, many of the time we fail to secure the well control of bronchial asthma for many reasons, in fact. And today in my presentations, I'm going to focus on the reasons for uncontrolled bronchial asthma with a special emphasis on the reliance on the short-acting beta agonist and the underuse of ICS. So now let's start by the basic. As you know, asthma is a chronic disease with inflammatory process, and this is the main feature of the bronchial asthma is the inflammation. So as you see that we have to differentiate between the normal airway, asthmatic airway, and asthmatic airway during exacerbations. And as you see in the slide, there will be an inflammations that result in the thickening of the wall and constrictions of the smooth muscles, which result in air-trapped alveoli. And of course, all these features will constitute the symptoms of bronchial asthma in terms of wheeze, cough, chest tightness, and expiratory difficulty from the airway because of the inflammation. As other common chronic diseases in Saudi Arabia, bronchial asthma has a prevalence of 5 to 10%. And unfortunately, 68% among adults in bronchial asthma in Saudi Arabia, they are not well controlled. And this will highlight the magnitude of the problems and the quality of the life which is really impaired for those patients with bronchial asthma in Saudi Arabia. There is many contributing factors for the poor control of bronchial asthma in Saudi Arabia. One of it is the time to educate patients, and unfortunately we don't have enough time as a physicians to educate patients, and this is very commonly prevalent in a very busy practice and result in patients getting into complications. The other thing is the over-relying on the short-acting beta agonists, which complicate the problems and push the patient towards complications. Again, there is a poor adherence to the medications and the poor compliance on medications, so patients don't take the medication according to recommendations of the doctors. And then adherence to the inhaler techniques. We don't have a proper time to educate our patients with the proper techniques. So educating the patient is very important to ensure that the medication has been delivered appropriately and the maximum benefits has been taken by the proper techniques of inhalations. Now we will go together to just explore the local publication addressing the poor asthma control and short-acting beta agonist over-reliance. One of the study of Dr. Saleh Al-Muhsin, this was published in 2008, it's called AIR KSA. It showed that there is almost 7 out of 10 asthmatic patients in Saudi Arabia are in poor asthma control. So this is about 68 to 70% of our populations, they are in poor control of bronchial asthma. Another study which has been conducted in 5 major tertiary care hospitals in Riyadh in the Kingdom of Saudi Arabia, which has been allocated 300 patients for each major hospitals with a total populations of 1,060 patients, and the result of this study showed that the uncontrolled asthma of these populations were about 64%. And the conclusion was the control of bronchial asthma is still a major concern in our population in Saudi Arabia, and we need for that a lot of information to explore the factors that contributing for this poor compliance and poor control. Another study which was conducted in King Fahd National Guard Hospitals in Riyadh, which included about 334 patients, it showed 38% of the patients reported irregular use of ICS. And of course, there is many factors contributing for this behavior. And it showed with analysis that about 59% of those patients, they use it when it's needed. And about 21%, they prefer using the bronchodilator rather than the ICS. Another study which has been published in the Annals of Thoracic Medicine in 2015, and this was conducted in outpatient departments in the King Abdulaziz Medical City in Riyadh, which was involving about 400 patients. And the objective of this study was to explore the facts that affect asthma control. So this result revealed about 39.8% was the estimated prevalence of uncontrolled asthma among the total populations of the involved group in the study, and 44% of the patient inappropriately used the inhaler device. So this is a quite important behavior that has to be tackled. And again, 79.5% of the patient reported that they stopped asthma therapy once they felt better. So this is another behavior that has to be tackled during the management of our patient with bronchial asthma. Another important study that I would like to share it with you in this presentation is the Asthma study, which is assessment of asthma control in adult asthma populations in the Middle East and Africa. In this study, 11 different countries in the Middle East and Africa has been involved, and Saudi Arabia was part of it with a population of 14% representing the total populations of the study. And the main objective of the study is to assess the level of asthma control in the Middle East and Africa and the relationship between the level of control and the patient and the disease characteristic, adherence, and quality of life. This study demonstrated elegantly that those patients who were controlled, they were only 29.4, and those who are partially controlled, 29.1, and uncontrolled is 41.5. So if we just collectively gather the partially controlled and uncontrolled, they are about 70.6%, which is almost representing the previous uncontrolled percentage in Saudi Arabia in the previous studies. And less than 1/4 of asthma populations self-reporting good adherence to their treatment regimen. So those who have been controlled, they are just only 1/3 of the total populations. And of course, there is many contributing factor and predictive factor for the asthma control. And of course, one of it is the poor medication adherence that results in a poor control. Again, active smoking, absence of medical insurance. Again, another important factor is the level of educations that varies between educated and non-educated people. So that's why we have to communicate with the level of each patient's education appropriately. So now we are talking about customization based on the patient profile, and one size is not fit for all. So we have to customize those factors based on the patient profile and make sure that we address it to make sure that we are providing the patient the best practice in controlling bronchial asthma. Again, one of the results that has been shown in asthma that there is a significant association between the level of asthma control and the quality of life. And quality of life is a very important indicator because this is one of the clinical outcomes that we would like to ensure that the patient lead a quality of life that is appropriate to lead his normal activities. So the overall conclusion from the asthma study was asthma control in the Middle East and North Africa unsatisfactory, with less than 1/3 of the asthma patients having controlled disease. So we have on the other spectrum, 3/4 of our patients are not controlled, highlighting the need for important treatment access, medication adherence, and along with a better follow-up and educations among healthcare providers and even as patients as well. So let's go together now towards a very interesting part of the presentation to highlight the international data about the control across all severities. This is one of the studies which called INSPIRE. It's a quantitative research conducted in 2004 to 2005 in different 11 countries utilizing telephone interview with physicians diagnosed asthma patients already on ICS and LABA. So INSPIRE had concluded with 3,415 patients, and as you see in the middle of the slide, 21% of the patients had partially controlled asthma using the asthma control questionnaire, and 87% of them perceived that asthma control was relatively good. So there is a discrepancy between the actual status of control of patients with asthma and their perception towards their asthma control. On the other spectrum, 51% of the patients had uncontrolled asthma based on the same asthma control questionnaire score. 55% of those patients perceive their asthma control is relatively good. So the things to be learned out of this study is that there is a discrepancy all the time between whatever the patient described to us based on their perceptions and the actual control of the patient. So we should not depend on the perception of the patient with the bronchial asthma in our management and our treatment. This is another study which called MAGIC study of patients with a physician-diagnosed bronchial asthma. There were about 1,286, and it demonstrated that asthma control was poor even at the GINA step 1. As we can see here, almost 52% of those patients in step 1 in a mild asthma, they were uncontrolled. So now we will highlight an important factor here for the poor compliance, which is the patient perception and behavior during asthma worsening. Another study which is called INSPIRE, the patient tend to increase SABA use immediately at the onset of the symptom worsening. And the increase usually goes more than 4-folds of the increase at the worst stage of the bronchial asthma and acute state. But in contrast with the ICS, there was no increase in the use of the ICS. In this study of release, it showed that more than 50 of patient prescribed preventer inhaler, they did not use it every day. So 50%, they said, I take it every day, and the other 50, they don't take it on a daily basis. So this slide represents the relationship between the mortality rate and SABA or ICS use. An over-reliance on SABA at the expenses of ICS control therapy was associated with increased risk of asthma-related death. And the episode of high reliever, more than 6 inhalers per day, at least for 1 day, were predictive for an increased risk of exacerbation. And as I see here in the graph, there is the more the patient uses canisters of SABA, the more the prevalence of the death, while in the use of more canisters of ICS, the ratio of the death will be minimal. And it's worth mentioning that 21% reductions of death usually take place by increasing 1 canister of ICS per year. A study in the UK National Review of Asthma Death, including 195 asthma death patients in the UK between February 2012 and 2013 January, and the poor controlled and under-treated asthma was found to be a major contributing factor for asthma mortality. For the year which was leading for the death, they have identified that 39% of those patients who died, they received more than 12